Wish you all a very, very good morning, good afternoon, or good evening, wherever you are. Uh, Hope you all are doing fine and nice to have you meet virtually in this podium of Sasomi. Though the entire program is primarily targeted at digital dentistry, I'm probably speaking on a topic which probably is the least influenced by digital dentistry as of yet. And that's what we call as a soft tissue management and manipulation around dental implants. I am Dr. Sudhindra Kulkarni. I run a practice in Hubli, and I'm also a faculty at the STM College of Dental Sciences and Hospital, Harvard. This is a disclaimer about my and my work. This is a place of work that's a practice in Hubli. Yeah. Coming to the agenda for today, let's understand that we all now know that when we speak about implants and implant dentistry, we all know now that the osseointegration is a phenomena that is taken for granted. We don't speak about osseointegration anymore. What we are now concerned about is aesthetics. We are looking at soft tissue outcomes around contour, shape, form. At the end of the day, we want to give our patients the kind of restorations they deserve, the kind of restorations we would be proud to deliver, and kind of outcomes that the implant that I place in the patient's mouth and restore it, I want it to last for the life of an individual, hopefully. Okay. There, however, when we'll start looking at various factors and parameters that would determine whether the implants that we do are going to last for a long, long, long time, we now know that the role of soft tissue becomes that much more important. Okay, the soft tissue uh, drape around dental implants determines the defense mechanism of the oral cavity and the tissues to continual bacterial and microbial assault. And that's why we start looking at understanding how we can improve the soft tissue biotype, which in turn would stabilize the marginal bone levels around dental implants and keep it guarded for the life of the implant that we have in the patient's mouth. When you start looking at soft tissue biotype, is a term that we describe to understand how thick is the gingiva around the natural tooth. The biotype is very simply described as thin, medium, and thick. Thin is where you can see the root translucency through the gingiva. Thick is where you actually have a highly keratinized mucosa and you also have a very good amount of connective tissue underneath so that the tooth are very, very well protected. The thin biotype cases are also involved with what we call as a triangularish teeth and a steeper papillae as compared to a thicker biotype teeth where we have flattish teeth, more squarish, and obviously much more better in handling. In our population, we also deal with what we call as pigmentation, which can tend to mask the kind of biotype or the tissue thickness that we usually tend to see in our patients. And how do I assess the biotype? Before I put an implant, before we put any implant in any patient's mouth, one of the most important assessments that we do is the assessment of the soft tissue biotype. And the easiest way to assess is take a graduated probe and place it in the gingival crevice. And if the amount of grayness of the probe that you see through will determine whether your gingival biotype is thick, thin, or medium. One of the terminologies that is actually a much better one to use is what we call as the periodontal bioform. The bioform describes the height, distance between the crest of the interdental papilla, between the two teeth, and the height of the gingival margin on the buccal side. What it does says is it describes the periodontal bioform as normal, high, and flat. The normal bioforms are where the distance is around 4 millimeters. On the other hand, the high bioform is where you have the distance which is much more than 4 millimeters. The high bioform situations are where you have triangular teeth. The papilla comes all the way to the junction of the cervical, junction of the middle and the incisal third of the teeth. And when you have a patient who loses any of these teeth, it's very, very tough to hold the papilla and then regenerate it all the way to the contact point. Then you have a flattish biotype. These are the best cases to handle where this height is lesser than 4 millimeters. Teeth are more triangular, or teeth are more squarish. And obviously, along with that, we've also seen that higher biotype has got higher bioform, has got thinner gingiva, and a flattish bioform has more of a thickish gingiva. Now, this tissue around a natural teeth is far more different than what we see around a dental implant. Comparing a peri-implant soft tissue and that with a natural tooth are probably creating false equivalence. The reason why I say this is because the natural tissue around a tooth is the gingiva, which has got high amount of connective tissue fibers running between the cementum, the bone, and the gingiva, which has got fibers running in all directions, which all are bracing and holding the gingiva towards the tooth. The biological distance of 2.2 millimeters, which is between the crest of the gingival margin to the crest of the alveolar bone, is the most critical zone, and that's what protects the tooth against all forms of assaults. On the other hand, the tissue that we see around a dental implant on the left of your screen literally tells you that this tissue, what we have here, is a scar tissue. What do I mean by a scar? The minute the tooth is out of the socket, the tissue that heals and fills into that area is a scar tissue. It is not native. It is not attaching to the cementum. It doesn't have fibers which are inserting into the cementum. So what we have is basically the parallel set of fibers running and attaching only to the alveolar crest. And as they attach onto the alveolar crest, we know that there are nothing horizontal holding it. Now what happens here is because it is scar tissue, it also has much lesser amount of vascularity as compared to the gingiva. There is no periodontal ligament blood supply around the peri-implant tissue. And by the very nature of a scar tissue, the scar tissue shrinks. And over a period of time, we all know that as the tissue shrinks, obviously the contour and everything changes. Now, why are we stressing so much more on a peri-implant tissue here is the biological width around a natural teeth is around 2 millimeters. And how much of a force you apply with a probe, the probe would never go and touch the crest of the alveolar bone. However, around an implant, the attachment between the junctional epithelium to the implant surface is not as strong. So if you take a probe and insert it in that particular area, in the gingival crevice or a peri-implant sulcus, the probe can actually detach the epithelial attachment and literally go and rest on the crest of the alveolar bone. And what it means is, it means that in this area, the bacteria and the toxins can easily go in and then attach and attack onto the crest of the marginal bone. That's why every time you see a marginal bone loss, always look whether you have adequate amount of tissue and the kind of attachment between the epithelium, the connective tissue, and the implant or the abutment interface. It's also imperative for us to understand that because the scar tissue doesn't have the kind of defense mechanism that the natural gingiva around the tooth offers. And for that very reason, we have to start looking at creating systems or creating a facility by which we can increase the vascularization of a particular area. Now, how do we increase the vascularization? I cannot put in blood vessels. I cannot get a periodontal ligament in between an implant and the alveolar bone. So the only way that we can have a much better tissue, much higher, much thicker, and a bit more highly vascularized tissue is to have a tissue that is more firm, to have a tissue that is keratinized, to have a tissue that is a bit more bulkier than around a natural tooth. So the biological distance of 2.2, what we have around a natural tooth, around a dental implant, it would end up becoming 3.5 to 4 millimeters. The distance between the crest of the alveolar bone to the free mucosal margin around dental implants has to be around 3.5 to 4 millimeters, because the higher the thickness of the tissue that we have, better will be the blood supply, more is the resistance of this tissue to allow the bacteria to hit into the alveolar bone. Studies by Linkevicius have shown us very clearly enough that if we have a tissue thickness which is more than 2.5–3 millimeters to the crest of the alveolar bone, we obviously will not have any kind of a crestal bone loss around a dental implant. So it's imperative that we have good amount of tissue around a dental implant to prevent any crestal or marginal bone loss. And this tissue, what we develop or have or generate rather around a dental implant at the time of implant insertion or uncovering or at restoration, has to be maintained over a period of time. So this presentation, we are primarily targeting at those procedures which help us achieving excellent amount of soft tissue outcomes around a dental implant. It's not only for aesthetics, but it's also for functionality and for defense and long-term stability of the marginal bone levels around dental implants. And that's what this picture shows. We just do not have the adequate amount of blood supply around an implant as compared to a natural tooth. Let's look at this clinical situation. This is a case treated in the year 2005. We have followed it up till 2014. This is a case which now shows us that she has a flat gingival bioform. This is a young girl then. Okay, you can see the gingival contour looks very good. Teeth are squarish, flattish. So we did a conventional implant placement, temporization, and then final restoration. We finished the case in 2005. And by the time we followed her up for last in 2014, you can see that the mucosa or the peri-implant mucosa around the tooth number 21 looks very stable. You can still see that, however, it doesn't have the kind of stippling that it has or it is observed around the natural 1 or 2-1. 1-1 obviously shows no stippling or minimal amount of stippling as compared to the adjacent natural teeth. But however, because this patient had a thick gingival biotype, high or what we call a flattish gingival bioform, and for that very reason we now see that the tissues over a period of literally 9 years have been absolutely rock solid stable around this particular implant and its restoration. And that's what has also maintained the tissue around it, bone around it. Now, when do we start looking at intervening soft tissue or soft tissue management around dental implants? This is my flow chart. We can start intervening to manage the soft tissue around dental implants right now at the prior to extraction. So either at extraction or prior to extraction. Second is you can do it at time of implant placement. And third, at the implants uncovering or at second stage procedures, and sometimes even after restorations. So you can manipulate the soft tissue around the dental implant at various time intervals. You can prevent it by doing procedures like orthodontic space closure and extrusion even before the tooth is removed. You can do the soft tissue procedure at the time of extraction. You can do it at implant placement, at second stage, and even after restoration. Now, what are the different types of soft tissue grafting or procedures we do? We can do all the types, whether the soft tissue grafting, what we do can be a pedicle graft, it can be a free graft, it can be mucosal or de-epithelialized, or also known as connective tissue grafts. On a surgical procedure classification, this is it's my own personal classification. We start with palatal rotation flaps, apically positioned flaps, pouch and roll technique, vascularized interpositional connective tissue grafts, pouch and tunnel, and layered. And both of these can be epithelialized and de-epithelialized. So you can have a de-epithelialized palatal graft. You can also have epithelialized. You can have an epithelialized apical position, de-epithelialized. So a combination of both can be used depending upon the kind of clinical indication that we are dealing with. Why is it so important? This is a classical clinical recommendation given by William Gianoble and the team at the Osteology Foundation Consensus, published in CYR 2018. I'm just reading out the recommendation, and what does the recommendation say? The mucosal thickness. Regarding the mucosal thickness, the clinician may consider the use of autogenous soft tissue grafting to promote peri-implant soft tissue health or marginal bone levels at implant sites with insufficient tissue dimension. What we mean by the word insufficient tissue dimension is the dimension of the tissue should be at least 3 millimeters. Okay? And at the time of increasing, you can either use a connective tissue or a free gingival. Regarding the zone of keratinized tissue, it is anticipated that plaque control is much better facilitated at tissue which have more than 2 mm of keratinized zone. So it's always important that it's not just the bulk, but you also have a good zone of keratinized tissue and not just the loose tissue around dental implant. Okay, and if you want to increase the keratinized tissue, and the best tissue for that would be a free gingival grafting. One more thing coming from the Kato and the Japanese group, they published in the Journal of Prosthodontic Research. They studied 34 patients with implants with conical connection and aesthetic zone. What are the conclusions? Regardless of the bone and soft tissue augmentation procedures, implants with conical connections may effectively preserve peri-implant tissues. Now, but however, my take is that irrespective of the kind of connection you have, as long as you have generating 4 mm, 3 mm, 3.5 mm of tissue above the mouth of the implant, you will have stable crestal bone around. One of the important findings of the study is the thickness of the peri-implant soft tissue is essential because change in soft tissue margin level tends to be affected by thickness of the peri-implant tissue rather than bone width. So what it means is you may have a 5 mm, you may have more than 2 mm of bone on the buccal and the lingual sides of an implant, but if you have 1 mm tissue, the amount of bone that you have becomes immaterial. It's always important that if you have 2 mm of tissue around the bone around the dental implant, it's also important that you have at least 2.5, 3 mm of soft tissue around it. If you have, so it means that It's not just the bone, but it's also the kind of the tissue and the quality of the tissue on top of the implant. It's more important in guarding the peri-implant bone and not just the preoperative bone width. So it's not just the bone, but it's also the implant, the soft tissue width around the dental implant. That's far more important. So if I am putting an implant having more than 2 millimeters bone buccal and lingual to it at the crest, I also want to have a soft tissue which is at least 2.5, 3 millimeters. Putting an implant with 2 mm of bone around a dental implant, but having 1 mm of soft tissue, it means that I am anticipating bone loss to happen in this particular situation. So let's start looking at some small cases, and I've picked up very few cases just to illustrate the importance of keratinized tissue and soft tissue around dental implants and deliberate a little bit around the cases. This is a case. Why I am showing a overdenture, because when we start learning implants or when we start teaching dental implants to all our students, we always say that the most important and the simplest and the most safest of all cases are mandibular 2 implant retained mandibular overdenture. Now this is a case done in 2005, and what we see here is we have 2 implants which are placed in the mandibular anterior area. Though it's safest when it looks to bone and when it looks to no anatomical limitations, the issue around here in the mandibular anterior area is that you do not have adequate amount of keratinized tissue, and that's what has led to this case now developing peri-implant inflammation around that abutment in the 4th quadrant. Okay, now you see that there is a pouch, there's a small pocket kind of a thing that's got created around that abutment. Now, how do we sort it? The only way, so what we're doing in this case, when we are doing or restoring this case, okay, the implants are placed, allowed to heal, apical displacement of the flap was done on the buccal side, and that's what we have on the tissue level now. Okay, now let's look at this case. In this case, we absolutely have no zone of keratinized tissue around dental implant. There's hardly any vestibular depth there. There's no keratinized tissue around this area. Now, if you do a conventional crestal incision to open the implant mouth and then restore it, then you're going to have a free pocket around this particular implant. Okay, so in these are the cases where you do a free gingival graft. Okay, you go to the palate, harvest the graft. Okay, and then of late, I'm finding this technique of tucking the soft tissue into the healing abutment and then suturing around. This is what we call popularly known as a poncho kind of a technique, the Spanish skirt kind of a thing. So what you do is you keep the part of the graft epithelialized and you keep the part of the graft deepithelialized. The part that is surrounding the healing abutment is epithelialized, and the part that gets tucked into the underlying recipient bed is deepithelialized, and you suture it. Now, when you do this, what happens? You not only increase the width of the keratinized tissue around the dental implant, what you also do is you increase the bulk of the tissue around that. Okay, so that's how you close it. And then when this tissue heals up and when the patient is ready for restoration, now what we say is you see adequate amount of keratinized tissue around the dental implant. When you have adequate amount of keratinized tissue and tissue bulk, it becomes maintenance free. Means patient can easily brush. There's less chance of inflammation, and because we have good amount of bulk around that particular area, the amount of blood supply is much higher than in the situation if I had just done a small crestal incision and opened up and put the ball abutments. So this case goes to show that you have to use a free gingival graft in those situations where you do not have adequate amount of keratinized tissue. Let's look at one more situation, mandibular posterior area, where a patient was edentulous for a long duration of time, this patient. So we had to do a bone augmentation. So a block graft was done, and now the patient was ready to restore, to be restored with the final restoration. So at uncovering, now you see that because the graft was done and you move the buccal tissue to get a primary closure, we hardly have any tissue at the crest and we hardly have any tissue on the buccal. Now, these are the situations where you can do, or rather the recommended technique is to do a free gingival graft. So what we did was we harvested tissue from the palate, and then on the buccal aspect, what we did was we sutured the keratinized tissue. Whereas on the lingual, to increase the bulk of the tissue, we stuck in a connective tissue on the lingual pouch. So what we did a free connective tissue graft on the lingual, and we did a free gingival graft on the buccal. Now, as the tissue heals over the next 2-3 months, and by the time the patient is ready to receive the restoration, now you see that the tissue contours around these dental implants are beautiful. You have healthy zone of keratinized tissue on the buccal and a good bulk of tissue on the lingual. Okay, and by the time we restore this case, that's how it looks. The teeth look beautiful, the soft tissue contours look wonderful. And this is probably at 3 months post restoration. When the patient comes back, you see the tissue looks so healthy and nice. And this is what is going to guard the crestal bone around the dental implants in this particular case. So we are manipulating the tissues to get adequate zone of keratinized tissue around the dental implants. One more situation in the mandible, very, very common, but very commonly neglected. We put the implants where the restorations have to come. Now, this is a case where the keratinized tissue is on the buccal. We hardly have any tissue on the lingual. So when we're looking at restoring of this case, if you open the crest at the top or do a punch or whatever, then you just do not have any lingual tissue. And what's going to happen as the patient loses some amount of crestal bone for some whatever reason, then the tongue is going to rub against this area and the patient is going to be constantly complaining to you that the tongue gets hurt every time he or she speaks. Okay, so what we do now, we make a mid-crestal incision, separate out. We have good tissue on the buccal, so that's not our consideration. So we go to the palate, harvest the tissue. In what form we harvest? We harvest the free gingival and then de-epithelialize. So we leave a part epithelialized and de-epithelialized portion on the buccal and on the lingual, as you see there, and then tuck it. So now what happens? The epithelialized part go on the top and the de-epithelialized underneath. Over a period of time, what happens? This is exactly the way a schematic procedure is going to do. Make an incision, move the tissues out, the native tissues, harvest on the palate, de-epithelialized portions go underneath the native tissue area, and then you suture it up. You don't actually bite the graft at all. You just take the bite onto the buccal and the lingual. And that's how it would look from the occlusal view. As the patient heals up over the next week, now you see that you have adequate amount of tissue on the buccal and all on the lingual side. The quality of the tissue looks fabulous. You actually notice that there was no lingual vestibule. Now we developed a lingual sulcus vestibule there. We have a good zone of keratinized tissue. Now the patient has to undergo small nick, exposed, the healing abutments are in place, and now this patient is ready to be restored with adequate amount of tissue on the buccal and on the lingual side. And this restoration would last the patient a long time. Let's look at one more case. Now what happens every time you get a good zone of keratinized tissue is this. Let's look at this case. Patient with absolutely no tissue. This is done way back in 2009, I think. At uncovering, go to the palate, harvest a free tissue graft. We tuck it on the buccal and lingual, suture it, secure it at the base, and then that's the tissue. This is on the day we are cementing it. On the day of cementation, you notice that here, just a minute, this is keynote problem. If you go back, the whole thing jumps up. Yeah. So this is how the tissues were on the day we are cementing. You can notice that still 1 mm of the neck of the implant is exposed on the distal most implants. We restored it up. And then now we start seeing at the follow-up. This is at the first month follow-up. This is at 6 months follow-up. Now you start seeing when you have a good zone of keratinized tissue, the tissue starts creeping up. So the metal collar, what we had, which was exposed, now is getting covered up slowly. This is what we call the creeping attachment. Now you see that the amount of keratinized tissue is more than 2 millimeters there, and that has facilitated hygiene. This photo was not taken after cleaning up. It was taken the way the patient came in. And now you see that the hygiene is excellent at the end of 1 year. Okay, now this is what we see a comparison. That's 2010 and this is 2019. Over a period of 9 years, okay, you see that the tissue around the dental implants is rock solidly beautiful. And you can see the zone of keratinized tissue has just held up. And that goes to show that why is it important to hold a good amount of keratinized tissue around dental implants? It's a key to long-term crestal bone stability. And that's the radiograph of the patient and follow-up. Let's look at maxilla now. When we start looking at the maxilla, if the implants are going like this, okay, we do go back to the maxilla, make a split thickness flap split, full split, what we call. Okay, harvest the tissue from the retromolar area and the adjoining edentulous ridge, secure it up. So now we have what we call as a free gingival graft holding on to the buccal aspect of those 3 implants. suture up. You could have even left the tissue naked on the other area instead of getting a primary closure. Now in 2009, by the time we were ready to restore, now what I have, we do not have any tension on the buccal margins. We have good thickness of the tissue around these dental implants. You can see that the good zone of keratinized band is looking stable. Patient gets restored, comes back for follow-up in 2014. In 2016, we added additional implants for him in the posterior as he lost those naturally. But what we see consistently, look at the quality of the tissue and the level of the tissue what we have on these dental implants, which were done in way back. Okay, the tissue levels look rock solidly beautiful and stable, and that's what is important. One of the simpler tissues, procedures that we all can do is this. When you have cases where you have frenum and you do not have adequate amount of tissue, then what we do is, in the maxilla especially, is a palatal flap displacement. What do we do here? Now this is a case where we have done bone augmentation to secure good bone there. And as you get a primary closure and advance the flap, you obviously lose the vestibule. And as you lose the vestibule and also the zone of keratinized tissue, by the time the patient comes for restoration, you need to get the tissue back. If you don't get the tissue back, hygiene becomes difficult. And for that reason, now we go to the palate, displace the tissue from the palate to the buccal. You can see that connected the free gingival, not the free, rather the palatal pedicle has been shifted to the buccal. As the patient is restored up, now you see that the kind of tissue what is there, it looks thick, solid, and beautiful. And the patient gets the tooth. Now this is a follow-up. You look at the tissue there and also the bone levels. Let's look at one more situation. When you have multiple teeth to be treated in the posterior maxilla, the implants are gone at the crest of the bone, closed. Now, at the time of uncovering, okay, instead of making a crestal incision and just chopping out or doing a punch, what you do is displace the tissue onto the buccal. As you displace the tissue onto the buccal, you get good zone of tissue. Also, the frenal pull that was working earlier has been negated. Now you can get good bulk of the tissue there, which is going to guard our restorations and the crystal bone around these implants. Now you see that the teeth look beautifully restored, and more importantly, what we see is the zone of tissue what we have is going to hold up for the life of this patient. One more situation exactly in the maxilla. This is a thin biotype case. Biotype thin, what we mean here is that you can see the cover screw through the mucosal margin. You also do not have much of the buccal contour. I don't have buccal contour, nor we have what we call as the tissue width there. So what we do, we go back to the palate. There are no second sides. Just open the palate, displace the entire tissue onto the buccal. Now, because you displace the tissue to the buccal, you need to do something to close the inter-implant area. And that's why you take small pedicles from the palate and shift it and suture it. So you basically do not leave any raw area in between the implants. So now what we've done, we've displaced one bunch of tissue onto the buccal and we created a pedicle to close the inter-implants area. Now what I obviously have much better contour than what I had before. And by the time I restore it, I have good zone of tissue on top of the implant. We have more than 3 mm vertical tissue, and we have at least 2 to 3 mm of buccal vertical thickness, and that's what is going to guard the bone around these implants. Let's look at one more situation now. This is pre-operative. This is at the time of implant placement. Okay, the time of implant placement, you can do a full palatal rotation flap. At second stage, what we do now, you get excellent generation of the contour, and you can restore up these cases very, very beautifully. And what happens, the better the tissue, you obviously have better bone around these implants. Let's look at this one more situation. We have an immediate post-extraction implants case here in the maxillolateral incisor. Okay, and as we treat up this case, the implant is not rock solid stable, so we decided to submerge it. Now, when you want to submerge it, how will you close this? You can either do a socket seal by taking your free gingival graft, punch and seal it, or you can do a small pedicle. So what you do, just go to the palate, extend an incision, epithelialized pedicle graft. You can just go ahead and close it the way. It's literally like moving the tissue from here to here and close it. And because the palate is going to have a layer of connective tissue left behind, it's just going to heal up very nicely. And because we now have connective tissue covering the lid, you can see how beautifully the tissue is healed at the end of 3 months. By the time you finish the case, you generate adequate amount of tissue to hold onto the buccal aspect of the implants. Let's look at one more technique, very, very important. Off late, instead of doing epithelialized pedicle on the palate, we shifted to doing de-epithelialized because it's much more painless, much more less discomforting to the patient. Let's look at this case here. Maxillary central incisor. This patient happened to be a colleague. She is a dentist herself and the best friend's wife. Okay, now you can understand all the complications. She had a very high smile line, all those things that can happen. And you can see the radiograph and the CPCT absolutely showing no bone on the buccal. Okay, so what we do, we decide the extraction and socket graft. Now, when you're socket grafting these kind of situations without any buccal bone, you also need to look at getting absolutely high degree of primary closure and good tissue around it. Okay, so what we do now is do a vascularized interpositional tissue graft. Go to the palate, make an incision, you remove the tooth, curate it, put a membrane, and then from the palate, you displace the connective tissue. Now, as you do displace the connective tissue, which is pedicled, this entire pedicle, what you see there, is going to get its own blood supply, so it's not going to involute. Whereas, because you remove only the connective tissue and have left the epithelium, you just get a nice primary closure on the palate, so post-operative discomfort for the patient is negligible. As the patient heals up now, over a period of next 9 months, when we allowed this case to heal up, okay, you now have the entire socket, which is very well healed up. There's absolutely no loss of buccal tissue. Okay, so you make a small incision, get the implant in, and restore it with a temporary immediately, because the bone that's healed into socket at the end of 9 months or 10 months is very, very beautiful. Okay, and this is how the tissues are at final impressions. Okay, now what we see here, excellent zone of keratinized tissue and beautiful soft tissue contours around them. Because the reason we did not have any buccal release incisions, there are absolutely no buccal scars on this particular situation. That's the biggest advantage of moving the tissue from the palate to the buccal. One more situation, it's a socket shield situation, maxillary canine, one of the toughest teeth to treat. Okay, so we had a periapical grade in lucency in this case. So when we opened up, we kept the buccal shield, removed the apical problem, put the implant, grafted, and then we now did a VIP CT to cover this implant because we did not have excellent primary stability. Okay, so what happened? That's a vascular interpositional graft going in, and that closes the socket seal. And also what we also do here is the palate has a primary closure, so the patient can go back without any issues. When the patient comes back at the end of 3 months for uncovering, now you see that there is excellent amount of hard and soft tissue contours. It's actually over contoured enough. And you go ahead, restore up the case, and you see that the canine buccal contour is exactly the way the natural canine had. Probably we have now more tissue on the buccal than what the natural canine itself had. So that's the advantage of doing the socket shield and also VIP CT to cover the area. One of the most common and simplest of all procedures is what we call the palatal roll and the finger split in the maxilla. Look at this case with two congenitally missing lateral incisors. Okay, so this is a case on the left where we just did a nice simple contouring of the tissue to get the papilla and the buccal contours. Whereas on the other second quadrant, we didn't have the buccal contour. So as you go back and see this picture, because we were missing a buccal contour, okay, there was a buccal depression. So now what we do, go to the palate and separate it. And now what we do is I create a pouch and then roll the tissue underneath it. So I de-epithelialize the part and then roll this de-epithelialized part underneath the buccal flap. Okay, get a nice primary closure with use of IO suture so that it heals very well. We temporize it, and as the tissues heal back, you now allow the things to settle down. There is some scar formation here because we have gone for a release. If you didn't have a release, then obviously there wouldn't be any scar. Okay, and that's how it gets restored. The 2-2 has got roll flap, whereas 1-2 is just normal tissue contour. Now this at the time of cementation. Okay, and now this is at follow-up. Probably this is at around 6 or 7 years of follow-up. You see that the tissue contours on both 1-2 and 2-2 are very, very beautifully held up. Next, we come to those situations in the posterior areas of the maxilla where you will have to do a free tissue graft. Now we'll look at this case. We have missing 6 and 7. The case has undergone a sinus graft to build this one. We now do not have the soft tissue. We have a frenal pool there. So what we do, we go to the palate again from the same incision. So what we do is the incision with which you trying to uncover, you take the connective tissue from the same incision, okay, and then you bulk up the buccal. You uncover and you bulk up the buccal, you put the tissues there, and then as the tissues heal up, okay, you now have excellent amount of tissue around both the implants. You can see the zone of attached gingiva, and you can also see the kind of emergence that we've got on both of these molar teeth there. And that's how it looks at follow-up. You see the tissues just mature. When you get good height and good thickness of the tissue, as the tissue matures, it only gets better and not worse. And this is what is going to hold up our restorations for a very, very long duration of time for the patient. Let's look at one more case. This is a case where the implants have already been placed in the 2-1 area. This is a temporary. So when we start uncovering, we have a bit of buccal contour deficiency as compared to the tooth number 2-1 in the 2-1 area as compared to 1-1. So we make a small extension under the palate, take that small piece of tissue and tuck it under the buccal. Okay, that a very small amount, probably even a 5 mm length and by 4 mm width of tissue is just sufficient enough to get a decent amount of contour. At times, very simple procedures give very, very beautiful outcomes. So the tissue was tucked under the buccal. Yeah, exactly, that's the size of tissue. You can understand how big it is in comparison to the handle BP blade there. That's gone, tucked into the pouch, no suturing, just allow it to heal, temporize it, keep on contouring the temporaries. And by the time you're ready to do your final impression and restoration, now you can see that the implant crown and the natural teeth crown look absolutely identical. Now why? Because we just did not concentrate only on building the bone around that area. What the effort was also on getting a good amount of what we call as the soft tissue contour. It is to get the bulk as well as tissue thickness and the shape. Last but not the least case, what we would look at is gingival contouring. We start looking at having a lot of cases with what we call as altered passive eruption. Now this is a case, he is a student of mine, he's a periodontist himself. Okay, so when I was treating him, this is what happened. He had altered passive eruption, there's root resorption in relation to 2-1, that tooth had to go. So we first planned the round of gingival excision. So just a nice gingivectomy was done, implant was placed, GBR was done. And then at the time of uncovering, what we did was we thought the contour, what we have achieved was not adequate. So we did a second round of gingivectomy and then start temporizing. And now what happened was when we did the excision around the implant crown, we probably had a less of buccolingual thickness. The shape was good, but the buccolingual thickness was less. So now to get the buccolingual thickness and the gingival zenith between the natural teeth as well as the implant to be identical, we did what we call as a dynamic compression technique. So we over-contoured the crown, we kept it for 3-4 days, removed it, added and removed. So as you keep on adding and remove the composite in the cervical area by what we call as a dynamic compression technique. So what we do is you create inflammation and scarring, and because of this inflammation and scarring thing, what ends up happening is you get good zone of fibrous tissue around the implant crown. Now, by the time the patient was ready for restoration and finished up, we ended up in a situation like this. The tissue contours on the implant crown as well as the natural teeth restorations on which you did veneers look absolutely identical and beautiful. And that's how it looks by the time we restored up. This is nearly at the end of 1.5 years of follow-up. You see that the tissue health, tissue contours, and everything looks much better as well on the implant as well as on the natural teeth side. And this is at the end of 1 year. You can see it only looks better. It ages, it's just like a good wine. It ages well with time. Last but not the least is what we call as, can we develop the interimplant papilla? 2 missing teeth in the anterior zone probably is the toughest for any one of us to handle. Okay, every time I have a central and a lateral missing case, I'm scratching my head on how I'm going to develop the papilla. And this goes by the Tarno's principle. If you have 5 mm of bone, or if you have 5 mm distance between the gingival embrasure and the crest of the alveolar bone, you're going to have papilla. Anything more than that, the chance of you having a papilla is much, much, much lesser. Okay, so 5 mm is the key. 6 mm, your success rate dips by 50%. At 7 mm, it dips only to 27% of success. Okay, so that's the case what we have, a periodically compromised 1121. This is a case like this. So the first thing was, this is a case where you developed the soft tissue using orthodontics. Okay, so orthodontics was done, the space closure was done, we developed the papilla, the implants went in, and further space closure was done. At uncovering, we did the palatal roll to get the tissue thickness. And by the time we came to restoring up this case, the orthodontic treatment was complete. The teeth were moved into the final positioning. And now you see when we connected the final abutments, you can see the shape, the papilla, as well as the bulk of the tissue looks absolutely beautiful. It was probably much better around the dental implant than what the patient has or had around those natural teeth. The inter-implant papilla, inter-implant peak, everything looks beautiful. And that's how the restorations look. By the time we restored up this case, it looks as beautiful as it can be. And that's the two implants. That you can see the inter-implant bone is much higher than the buccolingual bone, and the inter-implant papilla looks very beautiful. This at the lower photo is at the end of nearly 3 months of follow-up, and the tissues only look good as compared to the day we had cemented it. Let's look at one more. I think this is the last case I will be presenting. This is a case, what we have here of missing central and lateral incisor. Patient had lost her teeth in a trauma. We had done already a round of block graft was done. The implants were placed. Now this is at the time of uncovering. When we started uncovering, that's the first temporary, that's the second and the third. As we start contouring the temporary over a period of 3 to 4 months, we end up eventually with this point. So the role of prosthetics, role of temporary restorations in developing an inter-implant papilla are very, very important. Okay, by the time we restored up this case, and also the choice of restorative materials. We had used custom-made zirconia abutments, zirconia crowns. Okay, and by the time we finished and restored up this case at the end of 1 year, it looks like that. You can see at 1 year follow-up. This at 5 years, you see the tissues look good. There is stippling. The papilla, what we had generated, has held up. It is not as sharp as a contralateral papilla, but it is there. It is there between the two teeth. It's not creating any aesthetic issue. Now, this is at the end of 8 year follow-up. What we see, you see that in this case, there was no soft tissue grafting done. We just manipulated, we played around with the tissue using temporary prosthesis. Okay, and for the fine restorations, we selected metal-free restorations, and probably that's the reason why this tissue and the papilla around 1-1 and 2-1-2 have held up very, very beautifully. That's what we're seeing here. So this is how the tissue condition is at cementation, and that at 8 years. Now, one more thing, what you can see here in this case is the bulk of the tissue has come down. You can see there's a buccolingual reduction. There's a bit of scarring that's come in there. The stippling is there at 8 years, which we did not have at cementation. But what we see is the papillary height are maintained. Probably this is a case which I would re-enter probably after few more years to do one more round of connective tissue grafting to get the bulk back if the patient desires it so. Okay, so that's how it looks now at 8 years, and you can see the emergence and the papilla, everything looks so, so beautiful. So what this goes to show is if you have good zone of tissue, you can also see that the crystal bone levels around these implants have absolutely been the same over a period of 8 years. So a good zone of soft tissue around a dental implant, there is a key to having the long-term successful outcome. Tissue thickness is very, very important, and at least 2 mm vertical, but I'll prefer 3 or 4 mm vertical, and at least 2 mm buccal tissue thickness is important. If you do not have keratinized tissue, you have to do a free gingival graft, and if you do not have vertical height, you can manage with a free gingival or a connective tissue graft. So with this, I would look at concluding my presentation on soft tissue management around dental implants. That's where you can reach me. Thank you so much, and hope you all have a nice virtual conference. I would look forward to meeting you all in person at some point of time. Hopefully we should start meeting in person than in what we call in this virtual forms. Hoping and praying that the condition that's affecting all of us, the COVID-19 pandemic, is over soon, the vaccines work, and hopefully we all should start meeting in actual form. Thank you so much, everyone. Have a great day ahead.